Do you see the slide?
Yes,
Yes,
sir.
All right. So as with any of my lecture, please feel free to interrupt me anytime if you have questions. Let me know if my voice is getting garbled or the slides are not moving. Okay? So today we'll be discussing joint diseases, infections, and two more. Let's start with joint pains. We want to understand the basic concepts of arthritis, understand the salient features and history taking, as well as physical examinations of patients. We know the general principles and management of arthritis. So please remember this slide. We categorize the different arthritis into non-inflammatory, inflammatory, infectious, and hemorrhagic diseases. Let's begin with the case of a 67-year-old female who consulted because of left hip pain. She initially applied liniments, providing temporary relief, but 1 month prior to consult, there's already progression of the problem. So this prompted consult. There's no fever, malaise, or loss of appetite. And on physical examination, there's no swelling or erythema, no tenderness, but there's limited range of motion on the area. So in this case, we want to see the patient's gait. We want to inspect the area, palpate the area if there's possibility of infection or any other conditions. Check the range of motion, how much limitation there is, as well as do special tests to diagnose the case. This is the X-ray of the patient. You notice the left hip compared to the right. And this is the side view and the frog leg view of the hip. You see that there is joint space narrowing. There is subchondral bone sclerosis. You see the subchondral cyst as well as osteophyte formation. So what could be the diagnosis? Let's begin the discussion of the different arthritis. First is degenerative osteoarthritis, which is a non-inflammatory type of arthritis. The etiology is unknown. There are factors, mechanical, dystrophic, immune, and genetic factors that play into consideration. But in this case, there is a failed attempt of chondrocytes to repair the already damaged cartilage. This may be subcategorized into primary, wherein the osteoarthritis has no underlying cause, and secondary, wherein there is an antecedent injury, probably because of a previous accident that led to post-traumatic arthritis or an infection that led to post-infectious arthritis. Okay? So the articular cartilage is thinned and deteriorated, exposing the bone surface, and with the grinding of those exposed surfaces, it leads to pain, especially on initiation of movement. So the patient will complain of pain after prolonged recumbency or prolonged sitting, and then once the patient is about to stand up, there's already pain because of the grinding of these uh, uh, ends of the bone. No? So there's reduced compressive stiffness and resiliency, and bones are unable to withstand the mechanical stress. There are presence of bone spurs, which are reactive chondroosteospicules or osteophytes. In the early stages, there will be stiffness and pain. If you notice, other than the big bones, there may be associated small bone affectation, seen with the hands here, with the Heberden's node and the Bouchard's node. But in late stages, there's already significant limitation of movement and some crepitation. There's pain at rest, and malalignment and subluxation may be present. Other than X-ray, we may also do CT scan if there are problems with the bone, and we can also request for MRI if the blood supplies in question or any other soft tissues wants to be investigated upon. The treatment first is conservative management with NSAIDs and physical therapy. So you want to uh, decrease the pain with administration of NSAIDs, and then strengthen the muscles surrounding the already degraded bones, and with strengthening of the muscles, the patient may be able to tolerate the arthritic area. You may also inject steroids to decrease the pain and hyaluronic acid to increase the um, to provide lubrication over the degenerative joint. Platelet-rich plasma and stem cells are still questionable. Latest evidence will show that PRP and stem cell will not provide additional benefit for the patient. So in these cases, we want to prevent deformity by splitting an exercise, and we may proceed with surgery if the we may proceed with surgery if the conservative measures fail. So this includes patients with severe debilitating pain, deformity, and limitations with regards daily activities. Okay, so we may do osteotomies, especially if only one compartment is affected. Here in this case, only the medial side of the bone is affected. So we may do osteotomies to improve the alignment of the bone. We may do joint fusion or arthrodesis, wherein we fuse the segment to decrease the pain, on the caveat that the patient will not be able to move the joint. And the most common surgery for these cases is arthroplasty, wherein you replace the joint itself. How about rheumatoid arthritis? This is an inflammatory type of arthritis. There is asymmetric inflammation of the synovium of at least 6 weeks of duration. This is the most common type of inflammatory arthritis, with an incidence of 1% in the population, women being more affected than men. So what happens is that T cells go against the soft tissues and later the cartilaginous chondrocytes of the ends of the bone. In comparing this with the osteoarthritis, we see that in osteoarthritis, there are thinned out cartilages and bone ends rubbed together. In comparison, rheumatoid arthritis will have bone erosions because of the swelling of the synovial membrane of the joint. So what happens here is that there is vascular dilatation, edema with fibrinous exudates, and there's the presence of pannus, made up mostly of lymphocytes and macrophages that denotes the articular cartilage, causing chondrocyte death. So this is insidious in onset with systemic symptoms and manifestations such as pericarditis, pulmonary diseases, and GI bleeding. It affects mostly small joints of the hands and the feet. Okay? Compare that to our degenerative osteoarthritis that affects mostly big joints. You may see subcutaneous nodules or rheumatoid nodules in 20% of cases. In the early stages on radiograph, there will just be swelling of the soft tissues, but on late stages, there is a narrowing of the joint space with punch-out areas of bone resorption. In advanced stages, there will be already bony erosions. Okay? The most sensitive and specific test, I want you to remember this, for rheumatoid arthritis is anti-CCP. With other blood tests, there will be leukocytosis in CBC. ESR and CRP will be elevated because these are inflammatory markers. Rheumatoid factor will only be positive in 80%. So it's not as sensitive and specific compared to anti-CCP. If you do synovial fluid analysis, the WBC count will be 5,000 to 20,000 per cubic millimeter. 4 criteria must be met. There must be morning stiffness, arthritis of at least 3 areas, including the hands and the joint, lasting more than 6 weeks, and the affectation is symmetric, meaning both sides are affected. There will be rheumatoid nodules. Rheumatoid factor may be positive. Anti-CCP will will clinch the diagnosis, and you will see the radiographic changes. How about gout? Gout is a crystal deposition arthropathy, affecting mostly males more than 30 years of age. What happens here is that there's disorder of urine metabolism, increasing uric acid, and with that, there will be deposition of MSU crystals inside the joint. You see this with creamy or chalky monosodium crystals surrounded by inflammatory reactions seen in the synovium, articular cartilage, ligaments, and periarticular surface. You will see the formation of tophi, which are urate deposits, as we have mentioned. It may also affect kidneys, forming renal stones. You see here the punched out periarticular erosions with sclerotic border consistent with gout. And when you aspirate the joint and you place the aspirate in the um, microscope, you see the MSU crystals, which are strongly negatively bifringent. Back to our case, what's your diagnosis of the 67-year-old female? It may be a degenerative type of osteoarthritis, and the treatment may initially be conservative management, but if the conservative management fails, and so that's what happened in our case, we proceeded with joint replacement to bring the patient back to her premorbid condition. So we templated the area and then did joint replacement. So that's how you answer the case of, on arthritis. You first look at the patient, categorize the type of arthritis the patient has, and provide the management based on the signs and symptoms. If the patient is able to tolerate the activities of daily living with conservative measures, then you can first advise the patient for conservative management. But if the patient is not able to do activities of daily living, then you need to consider surgical management. Okay? There are different arthroplasty types. You have the total hip replacement wherein you replace both the socket, which in this case is the acetabulum, as well as the proximal femur. In partial hip replacement, you only replace the proximal femur. In arthritic cases, in arthritic joints, it's best that you do total hip replacement because even if you just replace the proximal femur, such as in the case of partial hip replacement, the acetabulum of that joint will still have degenerative condition, meaning the patient will still complain of pain because of the exposed metaphyseal surface. So it's best that you do total hip replacement to remove all degenerative bone. How about the complications with joint replacement? One is infection. Any implant that you place inside the body may lead to infection. It may also lead to intraoperative fractures, especially if the implant place is too big for the bone. May also lead to nerve injury, especially with dissection of the area, which is very close to the sciatic nerve. It may lead to deep venous thrombosis, especially if the patient is not moving after the surgery. It may also lead to dislocations. And it may lead to leg length discrepancy, especially if the size of the implant is not sufficient. So please remember the complications of joint replacement as well. Okay? As well as, there's still another, aseptic loosening. The loosening of the implant inside the bone may happen 10, 20, 30 years after the surgery. Whatever implant you place there, over time, that implant will loosen and will need another surgery to place another implant inside. Okay, let's proceed to infection. We want to know the basic principles on acquiring the history and physical examination of patients with bone infection, understand the important laboratory and radiologic workups of patients with bony infection, understand the treatment options, understand the basic concepts of infectious arthritis as well as Pat's disease or TB of the spine. Let's begin with a 14-year-old male with pain and non-healing wounds over the distal thigh. 4 years prior to consult, patient fell from a tree and resorted to being treated by hilot or the bone setters in the local community that did multiple manipulations over the area. 2 years prior to consult, patient reported no yellowish discharge from the posterolateral thigh, and still manipulations by the hilot or the bone setters were done. Patient noticed multiple sinuses forming over time. So ROS and past and medical history and family history are unremarkable. Physical examination will show that the patient is unable to ambulate without assistive device, and there are multiple sinuses present on the posterolateral and medial side of the distal thigh. These are the pictures of the posterolateral thigh sinuses as well as the medial thigh sinus. We got CBC showing increased WBC. ESR and CRP are also increased, meaning that there is ongoing inflammation happening. If we look at the X-ray, you see the sclerotic area of the middle to distal third of the thigh, here both in AP and lateral view. So this may be considered as an infection of the femur. Osteomyelitis, or the infection of the femur or of the bone, is a progressive inflammatory destruction and apposition of new bone. There may be risk factors, recent trauma, and surgery. Patient may be immunocompromised. In our case, the patient has been receiving treatments from local bone setters that may lead to trauma over the area, and with repeated trauma, it led to infection. It may also be secondary to illicit IV drug use as well as poor vascular supply, and systemic conditions such as diabetes, which may predispose the patient to more infection, as well as sickle cell disease that decreases the immunity of the patient. It may also have secondary to peripheral neuropathies, wherein the patient is not able to have proper sensory function over the area, thereby not being able to recognize an ongoing infection. So there are three ways for you to have bony infection. One is by hematogenous route. For example, you have an upper respiratory tract infection, and that URTI, that infection, for example, of an URTI travel to the blood system and then relocated towards the bone. What's the most common organism if you're speaking of hematogenous route is Staphylococcus aureus. It may also be secondary to contiguous focus, wherein an injury on the periphery of that infected bone, an injury or a foreign object on the periphery and the soft tissue may lead to an infection of the bone. Or it may be direct inoculation. Penetrating injuries or surgical contamination towards the bone may lead to infection. Another thing is that if you had an orthopedic procedure and you inserted or applied an implant over the bone, and subsequently there is infection on the area, the bacteria will form a biofilm. It's like the bacteria forming a shell over itself that will not be amenable to IV antibiotics. So the only way to remove an infected implant inside the body is to actually remove the implant itself. That's the only way. There's no IV antibiotics that would cure an infected implant inside the body. The most common organism for this is Staph aureus still. So with bony infection, patient may present with pain, fever, erythema, tenderness, and edema. There will be limp or inability to ambulate, and there will be draining sinus. On the radiograph, such as in our patient, it will often show a lytic region surrounded by sclerosis. It may sometimes mimic a tumor process, and there will be bone loss. You have to identify which one is the sequestrum, which is the devitalized bone or the dead bone, and which one is the involucrum, which is the new bone formation. In the surgery, you need to remove the sequestrum and maintain the involucrum. You need to remove the dead bone, of course, and maintain the new bone formation. So which one is the sequestrum? Here, it is letter B. Sequestrum is letter B and involucrum is letter A. You see the sclerotic area here, this is actually a floating segment of bone. That is an infected bone. While in the area surrounding the infected bone, that is new bone formation, and you need to preserve that. Other imaging, aside from X-ray, maybe CT scan, especially for surgical planning, and if you want to check for bone destruction, you also get an MRI to check the soft tissue extent of the infection, and you may also acquire a bone scan to check for other bony affectation. WBC will be elevated. ESR and CRP will be elevated as well because these are inflammatory markers. Blood cultures may be taken to check for possible hematogenous osteomyelitis. But the gold standard, and I want you to remember this, will be to culture the bone to check which bacteria is affecting that bone, and it will guide your antibiotic therapy. Okay? It may be classified based on the timing. If the infection of the bone is within 2 weeks, it's called acute osteomyelitis. If the infection happened between 2 to 8 weeks, it's called subacute osteomyelitis. And if it has been happening more than 3 months, it's called chronic osteomyelitis. So in our case, wherein the patient has had this condition for how long na ba to? 4 years na. And 2 years with sinus formation. What do you think is this? Is this an acute, subacute, or chronic osteomyelitis? Anyone? So you may consider this as chronic osteomyelitis because this is obviously more than 3 months. Okay? Another classification that you can do with bony infection is the Schernimader classification. I want you to remember this table. Okay? Schernimader 1 is only medullary in location. So it's only in the medullary canal that's infected. In stage 2 or superficial, cortical surface is infected, but there's no defect. In stage 3, one of the cortices has been compromised already, but the other cortex is still intact here. Whereas in stage 4 or diffuse, all the cortices are already affected, leading to mechanical instability, leading to patient not being able to ambulate because of the instability. When you're talking about Schernimader classification, the first classification is the type, the medullary, superficial, localized, and diffuse. And the second part of the classification is the physiologic class of the patient. If the patient has no comorbidities, it is class A. If the patient has comorbidities, it's class B. And the patient who is not a candidate for surgery because of terrible conditions, that is considered class C. Okay? So in our case, let's go back to our case. Is this class, this is a 14-year-old, tama ba? 14-year-old patient with no comorbidities. Is this a Shirley Mader classification 1, 2, 3, or 4? Are all the cortices affected? So you may consider this as a 3 or 4, no? So one cortex is still affected. Knowing that the patient has no comorbidities, so you may consider this as a 3A or 4A. Okay? When treating infection, you need to do debridement. Remove the dead bone, send the dead bone to the laboratory to check for culture, and then provide IV and oral antibiotics once the bacteria has been isolated. The IV and oral antibiotics should have a duration of 4 to 6 weeks. Other than that, you need to provide stabilization because once you remove dead bone, it may lead to instability already. So you can provide stabilization by applying external fixation. Of course, you cannot place implants inside, such as in this case. You cannot place an implant inside the bone because that bone is already infected. And what have we mentioned when applying implants to already infected bone? It will form biofilm formation. So you cannot place an implant inside the bone if the bone is infected. So you can only place external fixators to provide stabilization. When we are talking infections, you think of three things: debridement, IV antibiotics, and stabilization. Okay? Remember that. I will not dive into specifics on elizarov fixation or antibiotic nailing, but just know that when dealing with infection, thank you, Vincent. When dealing with infection, you need, thank you. Yeah. Thank you. You need to provide proper IV antibiotics, which is culture guided. You need to provide adequate debridement as well as provide stabilization by external fixators. Okay? Complications may be persistence of infection or recurrence of infection that may lead to amputations. It may also lead to sepsis if the infection is not treated properly. And if the infection is neglected for more than 2 years, it may lead to malignant transformation, such as squamous cell carcinoma, seen in this picture here. Okay? The goal of the treatment is to eliminate the infection as well as provide bony union. But take note that the recurrence rate in adults, even up to this day, is around 30%. So you need to inform the patient that the patient may need to undergo multiple surgeries to completely eliminate the infection. So in this case, we did debridement and corticotomy. We removed the sequestrum and provided the patient with culture-guided IV antibiotics. So intraoperatively, we remove the sequestrum. This is the sequestrum. and then maintained the involucrum surrounding that sequestrum to provide, to maintain stability of that bone. So, because there's still um, a good structure of bone left, we did not anymore need to place external fixators. Okay? So we remove the sinuses as well. How about septic joint or infectious arthritis? Infectious arthritis, when these are secondary to bacteria in origin, may be secondary to hematogenous route or direct extension from an osteomyelitis. The most common organism is Staph aureus. Remember that. The infection in the bacteria will lead to cartilage destruction secondary to the proteolytic enzymes, and with increasing pressure, it will lead to more bone destruction. Patient will present with severe joint pain and inflammation. The diagnosis is made by aspirating the joint. If the aspirate is purulent or there's pus when you aspirate the joint, what's the treatment? So for example, a patient comes into your clinic, swollen joint, unable to ambulate with fever. Tapos you did aspiration of the joint. It turned out to be pus. What will be the treatment? Remember this, because this is one of the emergency procedures that we orthopedic surgeons usually receive. So the treatment will be an emergency arthrotomy. Siyempre, of course, when you're treating infected joint, the treatment will be to do an emergency arthrotomy, followed by IV antibiotics, which should be culture guided. How about TB joint? So this is secondary to an infection by Mycobacterium tuberculosis. It may also involve the spine, in which it's termed as Pat's disease. Okay, TB joint. When seeing a patient with TB joint, there will be limitation of movement. There will not be an obvious swelling. It's just limitation of movement, pain on ambulation, with difficulty of ambulation. And if you do your X-ray, there will be a obvious Pfeiffer's triad, wherein it's composed of osteopenia, joint space narrowing, and bony erosion. Okay, remember the Pfeiffer's triad, which is pathognomonic of TB joint. To diagnose, we biopsy the area, we make a small incision, and then get a sample of bone and soft tissue inside the joint, send it to the laboratory, and check if it's truly secondary to Mycobacterium tuberculosis. Afterwards, we give the patient anti-cox medication. We do surgery to debride the area and physical therapy to regain the range of motion. The TB joint may also affect, or the TB may also affect the spine. It's called Pat's disease. These are endemic in the Philippines and may also affect patients who are HIV positive because of their decreased immune response. The thoracic spine, I want you to remember this, the thoracic spine is the most common extrapulmonary site. So if you look at the anatomy of the spine, you have the anterior column composed of the anterior longitudinal ligament, the vertebral body, and the disc, anterior 1/3 of this. You have the middle column composed still of the vertebral body and the disc, as well as the posterior longitudinal ligament, and the posterior column made up of everything else, the spinous process, the transverse process, the interspinous ligament, the supraspinous ligament. So this one is the third column, or the posterior column. Okay? So which column is affected by TB of the spine or the Pat's disease? it's only the anterior column that's affected. So you see here, it's only the anterior column that is affected. And you see that the TB of the spine spares the disc. It's only the anterior 1/3 of the vertebral body. You also see here the purulent material because of that TB. So in early infection, metaphysis of the vertebral body and the anterior longitudinal ligament is affected. There may be skip lesions, paraspinal abscess formation as seen here, which is anterior in location. But in chronic conditions wherein the TB of the spine is neglected, there will be severe kyphotic deformity, and that kyphosis will progress. In layman's term, the kyphosis is termed hunchback. Diba? You see the hunchback of Notre Dame? Yeah, that's a sample of a TB of the spine, the Pat's disease. So it's a hunchback deformity. The onset of symptoms is insidious, and compared to that to pyogenic infection, there will be chronic illness, malaise, night sweats, and weight loss. Back pain is often just a late symptom. So you look at the kyphotic deformity of the spine secondary to Pat's disease. If the kyphotic deformity is severe enough, it will compress on that spinal cord, causing paralysis of the levels beneath that spinal cord level. It may also lead to mechanical instability. So chest X-ray will only show 66% abnormal chest X-ray, but still should be requested to rule out an ongoing pulmonary TB. Spine radiographs will show the anterior column of the vertebral body being affected with sparing of the disc, but in late infections, it may also affect adjacent vertebral bodies as well. MRI is the preferred imaging to check the extent of the affectation and how much compression it is producing to the spinal cord. CBC will show lymphocytosis and low hemoglobin. ESR will be positive in up to 25%. PPD, because well, as Filipinos, we have exposure to, most of us have exposure to TB, so most of us will have positive PPD. So this is not as useful as compared to other tests. The gold standard, remember this, the gold standard for diagnosing Pat's disease is CT guided biopsy. So you insert a needle, get a biopsy of that vertebral body, and then send it to the laboratory to confirm if it is truly TB in nature. Okay? If it is, then you proceed with anti-cox medication, and you also indicate the patient for surgery to correct the deformity and decompress that bacteria that is producing purulent infection over the spine. So other conservative measures that may help the patient would be to apply brace while undergoing anti-cox medication. Most of these patients will need surgical management to remove the TB infection by doing debridement, as well as stabilization by applying your implants. You don't need to memorize and to dive into the specifics of the stabilization part. That is for orthopedic residents and fellows already. But just know that after making the diagnosis for TB of the spine, you need to debride and to provide stabilization and give the patient 1 year 1 year of anti-COX medication. So complications is deformity, especially if not treated, abscess that may affect the retropharyngeal area, as well as respiratory compromise, sinus formation, and pars paraplegia secondary to spinal cord compression. Let's go to tumors. You want to know the basic concepts of tumor, differentiate between benign and malignant process, understand the importance of the laboratory workups and radiographic workups, and understand the various treatments of tumors process. We have a 15-year-old male with pain on the distal thigh. 3 months prior to consult, patient noted pain on the distal thigh with gradual swelling. 2 months prior, there's a sudden increase in the swelling of the thigh and is not able to ambulate afterwards. Because of this, the patient presented at RER. There's loss of appetite, malaise, weight loss, and you need to document these cases, okay? So let's begin our discussion with bone tumor. These are abnormal mass due to excessive multiplication of cells. The cell type, from where it originates, is the histologic type. This is either a benign process or a malignant process, and it may also be primary or a metastatic process. In benign tumors, there is a lack of capacity to metastasize. It is less aggressive and will respond well with minimal intervention. These are usually slow growing, these are non-tender, and it will not destroy the cortex of the bone. While in malignant tumors, they have the ability to metastasize. These are cancers. These are more aggressive lesions. They are fast growing and they produce unremitting pain and interferes with rest. And you will see the cortical destruction, the lytic destruction of the bone because of the aggressiveness of the tumor. This is the thigh of the patient. This is the inguinal region. This is the popliteal region and the knee area. The knee area. So this is the thigh of the patient that has grown in size over the past 3 months. Okay? So you want to document the size of the mass compared to the contralateral side. You want to check for color. Is there venous engorgement already? Is there sinus formation? Are there any wounds? And is there a sensory and motor dysfunction of the area distal to this lesion? You want to also check the vascularity of the distal pulses. So we request for LDH and ALP. This should be 3 times elevated if it is truly a tumor. Calcium is elevated if there is metastasis. So what imaging test will you request for this case? Initial imaging that you should request for this case. Anyone? You should request for. So the initial request should be X-ray. This is the most important initial imaging technique. It helps to diagnose and stage the tumor as to the location, the effect of the lesion to the bone, the response of the bone to the tumor, as well as some pathognomonic matrix formation. So we want to see the effect of the tumor to the bone. We want to check if the tumor is aggressive or benign. If the tumor is well delineated, such as in this case, well delineated, meaning you can differentiate the normal bone to the pathologic bone. So that will lean more towards a benign process. If you can differentiate between a normal bone to the pathologic bone, it means that there is a narrow zone of transition. Remember that term, narrow zone of transition. It means that you're able to differentiate the normal bone to the pathologic bone. Whereas in malignant process, there is a wide zone of transition, meaning you cannot anymore differentiate the normal bone from the pathologic bone. You also appreciate the lytic and moth-eaten appearance. There's a wide zone of transition, as I have mentioned. There's destruction of the cortex. You also notice that the periosteum on the periphery of the bone has already been disrupted. This is because of the aggressiveness of the tumor. So in benign lesions, there's a well-defined area of bone affectation. It is surrounded with a sclerotic border that delineates pathologic from the healthy bone. So there's a sharp zone of transition or narrow zone of transition. This is confined by the natural barriers of the bone, no? The periosteum, the cortex, the growth plate, and it lacks a destruction or the complete destruction of the cortex and lacks extension to the soft tissues. So this is a zoomed in version of benign compared to malignant process. Some characteristics of the common bone sarcomas. Ewing sarcoma will show onion skinning, shown here. Sunburst pattern, shown with osteosarcoma, and Cadman's triangle, here, also with osteosarcoma. How do you think Cadman's triangle happened? It is because of the periosteal reaction. So the bone is trying to contain the tumor, but because of the aggressiveness of the tumor, it has disrupted through that periosteal reaction. Ito yun, this one. That is the Cadman's triangle actually. It's the periosteal reaction of the bone trying to contain the tumor, but the tumor is too aggressive. You can request for MRI to check for extent of the lesion, bone scan to check if other bones of the body are affected, and chest CT scan with contrast because bone tumors commonly metastasize towards the lungs. So bone tumors metastasize either towards the lungs or other bone or other bony areas as well. Okay, so at initial consult, the patient presented with this X-ray. There is a fracture of the middle to distal third of the thigh of the femur. But 4 months later, this is already the X-ray. So you see the destruction of the bone, sunburst patterns. So what do you think is the diagnosis? This is an osteosarcoma of the femur. Osteosarcoma is the most common primary sarcoma of the bone, affecting males more than females. The most common site is the distal femur in the proximal tibia, so around the knee area. No? This is rapidly progressive with fever and swelling as associated conditions. You may feel the mass on examination, but the prognosis is already improving with 76% long-term survival because of modern technology. So you see the sunburst pattern, you see the Cadman's triangle, and you see the large soft tissue mass as seen with our patient. Now, the treatment options for osteosarcoma and other malignant bone tumors. Number one is amputation. Nowadays, we try to, as much as possible, we try to deviate away from amputations. Because of the advent of technology, there are a lot of options now to preserve the limb, the remaining limb that's not affected with the tumor. No? So you can first subject the patient to neoadjuvant chemotherapy, see if the tumor will respond, and if the tumor will respond, you can do your wide excision of the tumor. And then afterwards, give the patient an adjuvant chemotherapy. Along with the wide excision of the tumor, you can do some limb salvage procedures. Okay? So this is an example of a limb salvage procedure wherein we remove the entirety of the proximal tibia and then place a megaprosthesis over the knee joint that will still preserve the remaining bones that are not affected by the tumor. So that's an example of limb salvage procedure. So I have mentioned that with osteosarcoma, you can try to give neoadjuvant chemotherapy, see if the lesion will respond with chemotherapy. And if it does, you do your wide surgical resection. What does wide surgical resection mean? You have to differentiate between the different resections. One is intracapsular. Intracapsular means you're just removing or curetting through the lesion. Okay? Two, you can do your marginal excision when you remove the tumor along its reactive zone. So for example, you have a lesion, a benign lesion of the wrist, no? A ganglion cyst of the wrist. You know that that's a benign lesion. You can do your marginal excision by removing the capsule along with the tumor. Okay? So that's your marginal excision. How about wide excision? As I had mentioned with your malignant process, you remove the tumor, you remove the reactive zone, and you remove a cuff of normal bone and muscle. So most of the time, this is around 5 cm of healthy cuff of bone and muscle. And you can do your radical excision, wherein you remove the entire compartment. And in these cases, radical excision will mean amputation of the extremity. So in our case, because the patient's condition is not able to respond well with chemotherapy, we have no choice but to provide radical excision or amputation. In this case, we did hip disarticulation. These are sample pictures taken of the patient. Okay? You're already in your finals period and it's almost the end of the semester. Remember, I know you're all tired from studying, but remember, pain is temporary. Your fatigue and your tiredness just temporary. Do your best. Your personal best will always be forever. And with that, thank you for your attention. I shall stop my screen. Stop presenting.